About 40% of the savings are going to come from a drive around tariff in terms of the secondary care sector, and about 20% of the savings are going to come from big service change within that. That's a really challenging environment for us. And I said it on a number of occasions, this is the biggest challenge that a healthcare system in this country has ever faced. We have never delivered anything on that scale before, so very, very significant. And I know all of you in this room in one way or another are contributing to those kinds of changes. But important, absolutely, through all of this, is to keep the quality for our patients, but keep productivity going up and use innovation to make those things happen. And what happened about a year ago, no, not quite a year ago now, seems like a year ago, and we had an election and we had a coalition government who came in, acknowledged the size of the financial challenge facing us, did a settlement for the NHS, which is probably as generous as we could expect in the circumstances, and certainly significantly better than most of the rest of the public sector, and had some really radical views about the way you should change services. And the Secretary of State's been talking about those in the previous statement. A very comprehensive set of changes. The first time, in a sense, that we've tried to look at the whole system. When we've made change in the past, we've dealt with a bit of it over here or a bit of it over here. So the ambition to get hold of the whole system is absolutely breathtaking. And for me, it significantly increases the short-term risk related to the NHS and the way it operates. There is no doubt in my mind that the risks of facing us as an NHS over the next 2 or 3 years have been significantly increased as we go through the major organisational changes that we need to do. But we can do things to mitigate it. We can do things that will help and support us doing all of that. But my view is that the changes are absolutely necessary to support the long-term sustainability of the NHS. The importance of the NHS as a system which is free at the point of use and universally available has to be one of change, has to be one that focuses on outcomes. It has to be one that puts patients absolutely at the centre of what we do, and has to be one which has clinicians and frontline staff taking significant leadership positions as we go forward. So we're designing a system, but how can we in the short term make sure the things that we're trying to do will help and develop the whole issue around QIP? How can we connect the two things together? If we try and manage, on the one hand, the financial position of the NHS, and on the other hand, the reforms, it simply won't work. We'll get ourselves in the most appalling difficulty. So how can we use one to reinforce the other? And there are lots of examples how people are already doing it. At one level, a good example would be the development of GP commissioning, a really important part of the changes that we're taking forward. One of the things that we absolutely know, that the future viability of an NHS, of a healthcare system in the way that we have it, depends on the way in which we support and manage and help people with long-term conditions. A critical part of it. If we don't do that properly, we'll simply be engulfed by demands on the service and demands in particular on secondary care. GP commissioners are in an absolutely central place to improving that. So we need to get the pathfinders already are involved in developing new and innovative ways of taking forward improving the quality for patients with long-term conditions. In that way, you can get the reforms moving, but also have a significant benefit in terms of quality and productivity. And in terms of providers, about a third of our providers are not yet foundation trusts. A third of them are still directly, one way or another, accountable to Whitehall. How can we give them the freedom and ability to get on and make the changes that they need to improve services for patients? Foundation trust status in itself is a part of that response. Essentially, to be a foundation trust, what you need to be able to do is show that you are a clinically and financially viable organisation for the future, that your clinical services and your financial services are sustainable in the future. So going through that process itself will encourage and support quality, innovation, productivity and prevention. So we can use those parts of the reforms to drive the overall changes. Now, the commissioning system that's being developed is a significant change in the past in structural terms. But at one level, it is building on a lot of experience that we've already had, particularly around from GP fund holding through to practice-based commissioning. We have a huge experience and knowledge of general practitioners and general practice being at the leadership of commissioning. We've learned lots of lessons from that. And indeed, we can learn lots of lessons over the next 2 years in order by the time we get to 2013, when the consortia are up and running, when they've been given their budgets, they are capable of taking the service forward. So we have a lot of work to make that a reality. But I don't particularly want to talk about the consortia. There's lots of discussion about that. But I want to talk about the commissioning board and the importance, as I see, as Chief Executive Designate for the commissioning board, on how it can play a role. The first thing to say about it, it is a significant role. I know it just hasn't got much, it's not been highlighted very much, not been talked about very much, because all the focus quite rightly has been the main engine of change, which is the consortia. But nevertheless, the commissioning board has a significant responsibility. It has clear responsibilities in relation to about £80 billion worth of public money. It allocates the resources out to the consortia. It's responsible for essentially taking £80 billion worth of taxpayers' money and turning that into fantastic outcomes for patients. That's the reason why it's there. And at its heart has to be the idea of improving outcomes for patients. And the outcomes framework gives us a really clear way of doing that. And Secretary of State's absolutely right to reinforce the importance of that outcomes framework, the way that we deal with the big killers, cancer, coronary heart disease, COPD, all of those things. How do we take outcomes for those better? How do we make outcomes better for people with long-term conditions? How do we make outcomes better for episodic care, patients who have an episode of illness and are cured or operate on or have urgent care or whatever? And how we improve outcomes in terms of patient experience and how we improve outcomes in relation to patient safety. That needs to be at the heart of the commissioning system and has to be at the heart of the commissioning board. And that needs to be clinically and patient-driven. And so whatever structural arrangement you have for the commissioning board, that needs to be absolutely at the heart of it. So it has the responsibility of improving outcomes. And it has the responsibility of living within the cash limit. So what levers does it have? How does it make the system work? Well, it has some significant levers, I think, to make change happen. The first, and the one I mentioned earlier, was the one around allocating resources. Identifying where the resources allocated to commissioners, the resources, direct commissioners, practice-based GP consortia, allocating resources to the commissioning of primary care, the commissioning of dental care, the commission of pharmacy and optometry care, and the commissioning of the big national and regional specialties that the service has. So allocating those resources, a very important role and a big lever to make things happen. It also has the responsibility of directly commissioning significant amounts of healthcare, £20 billion worth of healthcare directly itself. And a huge opportunity there for us to do things in a way we've never been able to do them before. So all the stuff that's done on regional and national commissioning will be done directly by the National Commissioning Board. A real opportunity, I think, to bring sense and order into something which has grown up over the last few years in a relatively uncoordinated way.